Potentially.
Yeah.
Potentially.
Okay.
Okay. Hello. Thank you for coming. We're very excited to talk to you about failure and how we can turn failure into growth. My name is Leo Aliaga.
My name is Jeremy Brenzetti. We have our collaborators here who like everybody up at one time. Go ahead, Leo.
Hello, my name is Jeff Hill, one of the APDs at Cincinnati.
Erin McDonough, Program Director at Cincinnati.
Robbie Paulson, Associate Vice Chair of Faculty Development and Mentorship at Washington University in St. Louis.
No disclosures. So before emergency medicine, I was a neurosurgery resident at UCLA, and I was lucky enough during that time to have a really fantastic failure that's stuck with me since. And as I share that story with you, I want you to ask yourself, when was the last time you failed successfully? And on the flip side, when was the last time you failed in vain? So it was September 2013, and I was an intern rotating on the liver transplant service. And the transplant fellow asks me, says, Leo, we have a patient on the ward who needs a Broviac catheter removed. Do you think you could go take care of it? Well, a Broviac catheter is a tunneled central venous catheter that's held under the skin by a little ring of scar tissue. And to take it out, you have to dissect out that scar tissue and then pull. I'd spent the first 3 months of intern year rotating in the neuro ICU, basically getting facile with bedside procedures. And so, like as was the custom at the time, I look up a YouTube video on how to do this, and I think I can wrap my head around that. This is similar to what I've done. I got this. So I get my supplies, go to the bedside, numb up the skin, make an incision, and start dissecting that scar tissue. And everything's going okay, but maybe what I don't realize is I'm using sharp dissection instead of blunt dissection, dissecting maybe a little too aggressively, and the YouTube video said nothing about putting a clamp on the catheter above the area where you're dissecting. So, but things are going okay, patient's doing fine, and at some point I feel all the scar tissue go loose, ready to pull. I prep the patient, pull out the catheter, and what comes out? A piece about that long. I'd cut the catheter. I completely severed it. And in that moment, I can't tell you the terror that I felt and the fear and guilt and shame. I thought to myself, game over, man, game over. That's it for residency. And I frantically go and try to dig out the other end of the catheter, but it's already retracted way back in. I asked the nurse to page the transplant surgery fellows because I'm not going to figure this out on my own. They come, and they must have seen how scared I was, because they talked me off the ledge. They're like, hey, Leo, mistakes happen, and we'll figure this out together. And they both take their turns trying to dig it out, but to no avail. And we get a portable x-ray that shows it's sucked up all the way up to the level of the clavicle. So the patient goes to IR, they take out the catheter, and thankfully nothing worse happens to the patient. In the aftermath of all that, the transplant fellows, they sit me down, and I thought they were going to rip me a new one. But what did they do instead? They told me stories. They shared stories of their own failures and screw-ups during their surgical residency. When I think back to that experience, it was incredibly painful, insanely painful. But I was also incredibly lucky that something like that happened to me so early on in my training. Because without a doubt, I know I became a better proceduralist, a better surgical trainee, a better doctor, and a better teacher. And so you can imagine that a lot of learning came from that failure. But how does that work? What are the factors that allow failure to become learning? Another way to ask that is, what are the factors or moderators that dictate whether I failed successfully or failed in vain? And I'd like to propose the idea that you could take all those different factors and distill them down to an equation that looks like this. An equation that describes the relationship between failure and learning. Now, I know it's a bit of an artificial construct, but what it does is it gives us something tangible to talk about and argue and discuss. Do you think it should be like this or it should be like that? Failure multiplied by the sum of feedback and reflection, multiplied by psychological safety, divided by shame, equals learning. And we'll talk about each one of these, starting with failure.
So you could imagine there's many forms of failure. When we do this talk in other circumstances, I get into the existential career failure I had. And there is targeted failure in this very specific event. There could be failure in a school, a class, et cetera, and lots of examples. But what it comes out of it in the similarity here is magnitude. What is the quantity, the impact, the ego challenge or the identity challenge? And that is going to be both. It's going to be a double-edged sword. The quantity of this can lead to immense learning, or it can, depending on the other factors here, lead to nothing and really to catastrophic ego, collapse. If you then look at the factors on the numerator, they will get to the point of what are the enablers, or in another way, also what must be present, right? Think back to your basic math here. If any one of these are a 0, in these factors, then you're going to get no learning out of this. So without feedback or reflection, some deliberate investigation with metacognition, you will get nothing. Without, at the other end of this, the psychological safety to acknowledge that failure is a thing. The failure did happen, and that it's not just running away, it's not just beating up on the person to whom it happened, but without the safety to be able to investigate that experience, there can be no learning. Then on the other end, by the denominator, the shame, the emotive element that prevents us from cognitively engaging. It's somewhat protective, right? When you feel ashamed, you then ignore the thing and so you don't see it. But it's also, in a way, ruminative. You just get stuck on it and perseverate and just get stuck on, I can't believe I did this. I can't believe this happened. And without being able to move forward, and the larger the magnitude of that, then you get to a lower amount of learning that will come out of this. And each of these are complex factors that all interplay together, that ideally you will maximize the numerator, minimize the shame, and get the most out of an experience which, we all societally tout the importance of learning from failure, but in reality we all hate it because we're a bunch of overachievers in medicine. And so how do you make the best of that? This is how we would propose, is a way to conceptualize making the best of that.
If you think back to that story I told you, like in that moment, I felt such intense shame. Sure, it was a small procedural mistake, but I felt such intense shame about myself as like a person, as like a doctor. Like I'm claiming this to be my life's work, and I just royally screwed something up. And like, what does that say about me? And so with all that shame clouding my head, you can think of psychological safety as one of the antidotes to shame. Because when those transplant surgery fellows came in, what did they do? They didn't chew me out. They said, they could have, but they said, hey, mistakes happen. We will figure this out together. And then after that, what did they do? They shared stories of their own failures. And in doing so, you can imagine that creates this sphere of psychological safety that's like literally a sphere protecting me from all the terrible things that are going on inside my head and all those thoughts that just cloud you and blind you to gaining the learning from that experience.
I was like, I think that's a perfect time to hand off.
Awesome. So we intend to pursue a small group exercise here. It's going to be a large group. I think we'll have a better discussion with that. So if you guys would all be willing to hopefully come forward so that we can not have to shout from the back of the room. I know we have to use mics for the sake of recording. We want to create a safe space. We just talked about the importance of psychological safety. And I think having some better proximity will facilitate that. So sorry to be a stickler here.
And just because we're making you move forward doesn't mean we're going to make you say anything.
That's correct. And what we intend by this slide here is vulnerability is often a very scary term. I know I have a very visceral reaction initially when I look at vulnerability, but if I dissect it down, vulnerability is also a skill, and it's a skill that I can practice, and it's a skill that I can get better at and deploy selectively. And I think is very important as we start to digest our failures and we start to not ruminate on it in a way that just feeds shame and guilt, but in a way that is productive and allows us to examine the failure in the first place and reflect on it in an honest way. And so what we would like to do here, I think since we're one large group, we don't necessarily need the QR code. We can just probably facilitate this. But we really want to open this up to the room, and we are willing to be vulnerable here, as well. Hopefully, create a safe space and lead by example where we can share our failures and not just share the narrative, but we really want to focus on the positive spin and the growth outcomes, the growth mindset that allow us to move on from failure in a way that is not just healthy, but productive.
So I'm happy to start. I will say that from my standpoint, my first real kind of introduction into failure was going through a divorce, which happened like right after I finished residency. And while I had felt like I had many small failures through life, like we all do, none of them had ever been as public as that was. I mean, when you go through a divorce, you're moving out of a home, you're splitting up friends, that sort of thing. And like I had changed my name back from my married name to my maiden name, so it was very, very, very public. And I remember feeling just a ton of shame. But then it was really interesting because at first I didn't really want to talk about it. But then as I talked about it, I was really surprised at how many people then shared with me, very similar to what you were talking about, Leo, as far as the fellows sitting down and sharing their own experiences. I had people like confiding about marriage difficulties to me that I had no idea about and all this stuff, and it really taught me that the importance of normalizing failure and owning it and talking about it. And because I think in a lot of ways those conversations were beneficial for the people having them with me in sharing kind of mutual feelings of failure. So that was like, I think, a really eye-opening thing for me, and something that I took forward then into being a faculty member, in that, I started then very openly talking about all of the dumb mistakes I had made as a resident and med student and whatnot with the residents. And like all of that seemed so much more trivial. And then in sharing that, made them feel okay about, their own experiences that we've all had, but for so many years, nobody ever really talked about. So that is my personal failure story.
I guess with that, does anybody else feel comfortable sharing either their experiences with failure or the ways in which they've seen failure be a powerful learning tool, either for themselves or for others?
Hi, I'm Jenna Thomas. I'm from WashU. So this story was from residency, which was not that many moons ago for me, but still far enough that I feel very old. So my experience with failure was feeling like a failure was when I was in residency, I was very depressed. And I had never been diagnosed with depression. I'd never really talked about it, never really talked about mental health. And then at one point, just right before the COVID pandemic hit, one of my residency APDs pulled me aside and said, "Hey, you don't look good. What's going on?" And I had to admit that things were piling up so high, I couldn't do it. I just was having kind of a mental breakdown, and I was kind of failing to be able to complete notes on time. I was really having trouble just sort of keeping up with the everyday stuff that was going on. And so I had to go and finally get therapy, essentially. She made me take the day off and gave me some time off and made me go and sort of acknowledge that I had a mental health issue that I was going to be sort of addressing. And so I started to talk about this and started to talk about how overwhelmed I felt and how things were really getting on top of me. And oh boy, the amount of people that I saw as very functional, very successful, very visibly sort of functionally happy people who had also struggled with the same thing was immense. And there were so many people that reached out and said, "I'm so glad you said something because I've had this experience too, and I didn't know where to start, and I didn't know if it was okay to say it during training or as a physician, and sort of be able to talk about it and give support." So since then, I'm now an APD at a program, and so I've been able to kind of share that experience very openly with my residents and being like, "Hey, it's okay to like say that you have a mental health issue that you're struggling with, just like you would have pneumonia, or you would have, whatever else, diverticulitis, whatever it is. And I've been able to see people not only circumvent kind of, breakdowns and really crises, but also deal with them when they happen, and feeling supported and feeling able to talk about that.
Vulnerability is a tool to connect with your learners. That's it.
Yeah, that's excellent. Anybody else? I think a couple things are really great in that story, and thank you for sharing. Not just being able to be vulnerable, but to find out that, as we've seen in several of the stories we've heard so far, that like failure is not a unique and personal experience. Like, it happens to everybody in a lot of different ways, and being able to kind of share and go over those experiences is helpful in terms of ability to grow. So.
Hey, I'm Jeanette Wolf. I'm from Bay State. I've been in this game for 30 years. I have so many experiences to share, but I would rather share a resource that helped me through a really difficult time. And the gist of the time is probably year 15, 16, clump of difficult airways, back to back, difficult for very different reasons. Had one resident, same resident, and in the anonymous sort of comment, made a comment about the airways. And that process is so layered, right? Because these anonymous comments, which are not anonymous, and you know who they're coming from, and then just this deep shame that I was not doing something that I should, and then the anxiety that I had for any procedure, because I would go to do, forget airways, but anything. I had to just pause for a second, because we were in a feedback lecture earlier. I think feedback's like pancakes or waffles. You put a little syrup in, and some of us are waffle people. It stays right where it should, and maybe doesn't generalize when it should. And others of us are pancake people, where that feedback goes there and it just spreads. And I'm probably a pancake person, and I've thought about this a lot. And there's a great book out there that says, thanks for the feedback. And my favorite thing about that book is there's a thing called the second grade. In the second grade, you get feedback on something, you screw up on something, and it doesn't go the way you want. It's there. Somebody's giving you evaluative feedback, coaching feedback, whatever. It's there, it's done. You can argue it, you can get defensive about it, but it's been said. But the second grade, and I tell this to our residents all the time, it's the grade you give yourself for what you do with that. And I've said to residents, like, look, if feeling really bad about this would make you do it better, yeah, feel really bad about it, but it probably isn't. So how can you take this really, really hard thing and turn it into the second grade? Because you control the second grade and how you frame that. And I think my final comment is that I think Scott Weingart was really helpful, because being in the game for so long, in the early 90s as a young female doctor, you make a mistake and you feel like you're the only person, because nobody talked about it. Everything got covered up, everybody brushed it over. So you would really think like, shit, I'm the only incompetent person apparently whoever has done this. And I think Scott was one of the first people, and because of his platform, was able to say, hey, we have to do really difficult things, and we don't talk about the mindset around doing those things, and we need to do that. And by him being a very sort of machismo male, I think it really helped our specialty. And so I think this is so important that we have a framework for this, not just for ourselves, but for our next learners, because man, when, some people say fail fast, that's their whole business model. That was Kayak's business model. Put something out, it doesn't stick. You can't fail fast in medicine. People get hurt. So, how do you have this mentality where you respect it, where it doesn't crush you?
I love that. Thank you for sharing that. And that pancake waffle analogy is like spot on. I love that. I think you're exactly correct. I mean, I think that we really, for so long, there's just been this mindset around failure of failure is something you need to avoid at all costs. And if you experience one, hope that nobody notices, don't talk about it, that sort of thing. And that's exactly the wrong way to go about it. And I think your point of giving yourself the second grade is a great point, because it's not so much the failure that defines you, it's what you do thereafter and how you respond to it. And this is something that I end up talking with a resident, actually at the Chief Resident Forum the other day. A resident was talking about how to deal with her classmates who had applied for chief and not been selected. Again, a big public failure that our residents go through, that oftentimes it's the first public failure they've ever experienced, and trying to convince them that okay, so you weren't selected in this, now what? What's your next step? What are you going to do with your time? How are you going to make yourself a leader within this program? And then, then when people are able to do that, I've seen them go on and have incredibly successful careers and achieve leadership positions and such, versus the people who can't do that. And, you just kind of wonder what if this had gone differently? But trying to teach people, it's not the failure, that's not where things end. It's much more how you respond and deal with and then learn from that.
I'd like to build on that with a little bit of a personal story. I have had to work quite a bit also on not defining myself by my achievements. It has to go back to the root of my fear of failure, which is very kind of fixed mindset. I think that's very native to me. And I think kind of going back to childhood, I can think through, I think a lot of us will level with this. You get good grades, you're performing well in school, you're an athlete, and you get accolade, not because of who you are, but because of your work and because of what you've done. And I used that to just build my identity around it. And I had this intense pressure, self-imposed, not from anybody else, there was no ill will there, to constantly be a high achiever, so that when I do fail, even in minor ones, my first response tends to catastrophize, because I don't know how to deal with it. I didn't learn those skills young, and I'm learning them as an adult, and it's painful to do so. And so I have two instincts with failure. There's a fail, and I involute, I self-shame. And I know now that that's what I'm going to do, and I have to work through it. But I have this avoidant tendency as well, that you were just getting to. And I think part of the same thing with the airway anxiety that you were just alluding to. It's easy to then say, if we have a clinical failure, avoid those types of cases when you can. Obviously, we have no control over walks in the room. But I had a clinical failure in my early faculty career of a missed subarachnoid with a horrible outcome. She came in, she had her sentinel bleed, I missed it. And you get that email from your colleague 3 days later, remember that case? And she came back devastated. She was a functional elderly lady and ultimately died. And my first instinct, again, self-shame. My other instinct was, oh God, I'm scared of the next headache that walks in. But then to regroup and move on from, I'm a horrible person, I'm a horrible physician, and defining my worth as this one miss, I chose to dive into the literature a little bit and did a ton of reading and hey, how can I avoid this in the future? What are the subarachnoid guidelines? How is this changing? And when I give this failure lecture to other populations, I talk about this case consistently. And every time I deliver it, I still feel that visceral emotion. I still hate admitting it. And I've talked about this a ton of times now, but it gets easier and easier and easier every time. And so pushing through that initial avoidance, really, I think it's conscious, but the effort does pay off.
Run towards the stuff that scares the shit out of you.
100%. How do you guys, as educators, because I'm pretty sure we all faculty in this room, save one. How do you guys, we've talked a little bit about responding to residents' vulnerabilities and failures, with respect to mental health. We've talked about the procedural misses. How can we better model failure for our learners? What do you guys think about now that we're on the faculty side? We can talk about our failures openly, and that's part of it. But anything else come to mind in terms of ways that you discuss failure at your programs or with your students?
Hi, I'm Mia Karmatson from Stanford. I'm a pediatric emergency physician. So I talk to them about, for example, a missed what have you, that I find out later on. And just to normalize that we're not perfect, and we can learn. And so they don't have to be perfect, but we're always striving to be better. And I want to model that we're always learning, we're not perfect, and I'll share my mistakes, and I'll share my vulnerability, and normalize that it's okay.
Hi, I'm Krista Mueller from WashU in St. Louis. Sorry I was late. So for kind of modeling some of the failure, when I give career development talks, I started as full-time clinical and then pivoted to research later. And like, there's some version of my life that on paper could be like, I became a doctor and then I did this thing and then I got this grant funding and like, look at me. But no, like obviously that's not the path for any of us. So I try and, I add a slide about I had a bad airway too, where carried a lot of guilt around that case later. I actually, I thought seriously about quitting medicine and then worked through it. And I put that in because that shaped the choices that I made later. When I talk about grant funding, I have the grants that I got, and I have side by side all the grants I applied for and did not succeed in, just because I think it's good for our trainees and even our peers and our junior faculty to know that even when we do succeed, it's usually after having 3 steps back. And it's, and then very much kind of highlighting how it's our peer support among our faculty that has been really helpful to kind of move through the next steps.
We have a really great simulation faculty at our, Robbie's just so excited that I'm talking about this. We have really great simulation faculty who have deliberately put simulated conversations about procedural mistakes and about failures clinically into their curriculum. So our residents actually come in being told hey, you put it in a chest tube and it, there was some complication with it, right? It's miscited, or there was a lot of pain, or you have a tracheobronchial fistula, whatever it is. And then they have to sit down and talk through how to talk to a patient about it and how to talk to each other about it and do some communication surrounding that. And I think that they're also planning for some other sort of clinical failure scenarios or complications like a bleed after giving TPA or TNK that we are actively sort of integrating into the curriculum to show folks that this will happen and you will have to have a conversation about it at the very least.
I think that's an excellent tool.
I would very much like to tout that from an expertise development side too, that is a venue for productive failure where you can do that safely, which the struggle we run into is that we work in a place where people can truly suffer from our failure versus the bottom line of the company lost some money. It's not quite the same thing. 2 quick points that had come to mind. One, about the failed grants. There's the concept of the failure CV. So, right, you can put together all of the things you didn't, the schools you didn't get into, the grants you didn't get, the positions you never got, you could take it to an nth degree, the people who dumped you. There's so many instances where, especially with high performing perfectionists, that can be a way to just be hey, this is actually my life, not this thing that somebody after 20 years says, Dr. So-and-so was chief of blah, 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 and it rose quickly, right? We all see this straight path only in retrospect, but in reality, it was a bunch of hitting dead ends and finally got somewhere. So that one really stuck out. The failure CV can be a great idea. The simple thing, going back to on shift, low stakes failure. I don't know the answer to this. Let's all figure it out and then talk about it again, right? Then that's the I don't know it all. And I'm also showing you how to navigate, oh crap, I don't know what to do right now, and figuring your way out without necessarily having to get to the point that somebody suffered from it, right? It doesn't have to be a miss, but just, I don't know the answer. Let's send an email and figure out in a day or 2 and talk about that, which could be helpful.
I think I agree with that completely. And that's something that I'm a big believer in as well, as educators and faculty, we have to show our residents that we can say, I don't know. And I'll hear sometimes my senior residents talking about, how tricks that they do to avoid saying, I don't know. And I hate that. Just say, I don't know. It's totally fine because that's where, that breaks down this whole concept of perfectionism that we're all chasing. That's an impossible chase. And I describe myself as a recovering perfectionist because perfectionism drove me for most of my life. And, trying to, demonstrating to our residents, perfectionism is not an achievable goal. It just isn't. And you're not going to be perfect. Get over it. I'm not perfect. And I think the simple I don't know is a great way of kind of stepping towards that.
And to even take it to another degree as well, like the emotional context around failures generally is like a negative or like a neutral, there's shame involved. But these sort of minor or low stakes type failures, these I don't know points, you can actually, like, as an educator, not just model that, but also like highlight it as a positive thing. Like, oh, cool, we got an opportunity to learn this. We got an opportunity to change. Like, we got an opportunity to grow and like expand our abilities because of this. And like having it as a positive thing can actually be very, very helpful.
The thing I'm hearing over and over is that there is no substitute. The sense I get is that there is no substitute for us showing that. You can talk about it as much as you want. You can show the cute Liz and Molly cartoons that show failure and success are two bricks that used to build the same wall. But there is no substitute for a learner or someone else hearing it from you, from your own experience. A lot of times at the beginning of a shift, I try to make it a point to actually tell them like a recent error or a recent thing I wasn't sure about as just like intro story time before shift. And we don't have to do anything about it. It's just like, hey, this is something that happened. This was my learning point. Like, yeah, just set the stage that, yeah, but there's no substitute for showing that vulnerability.
That was great. Going back to, going back to what Robbie said. Owning what we can, like really owning when something does go wrong. Is there a knowledge base? And going back to material. So sort of, again, controlling those little nuggets of things that you can to feel that you have higher competency in that area. The other big thing I'm a big sort of advocate for is intentionality. So when a resident has a really bad shift, I'll often take them aside and say, that was a really, really hard shift. That was a really hard case. How you go home and manage that tonight, I want you to be thoughtful about it. Because we're humans and habits creep quickly. And if you go home and manage this, like, I'm going to go get a beer on the way home, that's fine. But if that is your coping mechanism, and that's your primary coping mechanism, it might not be just one beer 6 months from now. It might be 2 or 3 beers. So the intentionality and where your resources are, what do you need to reset? And then giving yourself grace that I do not think we still talk in our field about how much we carry. Like, if we were peer reviewers, people in internal medicine, they're supposed to go back to maybe 1 or 2 really challenging cases in a period of 5 to 10 years. I think we all go through it in cases of months. Like, we carry a lot. And how we make our residents resilient to be able to have that, not just for 5 or 10 years, but for as long as we've all been in the game, is really huge. Thanks, guys, for the really great discussion. I think we're going to start to move on to the debrief. And you guys have hit on a ton of this. We wanted to hit on some literature-based techniques for what we can do as individuals, because we control our own personal outlook. And then what we can do basically as educators, as leaders, as mentors in the systems in which we work. So the first is actually out of Kristen Neff. She is a failure researcher who does a lot of work in mindfulness, and it's called the self-compassion break, and it contains 3 steps. The first moment is a mindful moment. You just take a pause, and you just listen to yourself and what you're feeling. Then the next step is the common humanity of, it's normal to feel this way. I'm sure other people feel this way. This is acceptable. And then, kind of granting yourself a moment of grace to move on. Takes a second. It's great for those in the moment failures. And again, sort of like what I was talking about a little bit before, the importance of separating self from action and self from behavior and self-worth from your performance is so key. So what other aspects of your identity really define you? What are the characteristics, the emotional traits, the resilience, the grit that you're going to rely on? I love Carol Dweck. and her work on growth mindset and fixed mindset. And what she discusses is the power of yet. And there's a huge difference between I can't do this and I can't do this yet. And that one word really changes your framing and allows for growth. And saying, again, we're all going to make mistakes, but in the future, I will get to this. I will be able to perform this. And that, I think, also takes off some of the emotional burden and normalizes it. I do this in my head all the time. I'm horrible to myself on first draft and have to then, challenge myself and say, you would never treat your best friend like that. Cut it out and reframe and move on in that way. So what can we do? Again, going back to Carol Dweck, we can actually change the outcomes of our learners based on the feedback that we provide. So there's a huge difference between praising process and effort versus praising performance. And I'll give you an example. So when you have somebody that is faced with a task and you say, good job, great work, you're so smart, that is praising performance. When you praise process and effort, wow, you're really responding well to that challenge. I love, the effort, the work that you're putting into this. Then when that learner is faced with a challenge again, they're more likely to actually seek out risk, seek out challenge, and seek out harder and more difficult tasks because you've praised their effort. Versus those that have their performance praised are more likely to choose a simple task because, again, what you noticed was their intelligence. What you noticed was, wow, that intubation was smooth. So when they are faced with a difficult one, they're going to go with what's familiar because it is safe. And again, as educators, when we praise process, we praise effort, we will then promote an environment in which taking risks is psychologically safe and encouraged. Again, focus on your learning points. What are our learners taking away from small failures as well as our larger, greater ones, both emotionally as well as factually, like we talked about with seeking out knowledge. Setting approach goals helps. So again, I want to seek out this challenge as to avoid this scenario of a possible failure. And we've talked ad nauseum about sharing struggles. I like to do this at the end of shift. I think it's great modeling, whether it's pre-shift, mid-shift, on-shift, whatever. Find a way to continue to share your stories because the humanity in medicine, our humanity and the humanity of the patients that we serve is why we got into this job. So the last thing I want to say again goes back to naming it. Big Potter fan. Harry Potter, throughout the series, thanks, Kristen. Thank you. I knew I liked you. So Harry Potter always says Voldemort, and he's one of the few characters that does the entire series. And his reason is Voldemort is fear, and when you speak fear's name, you can face it. It's harder when you say, we don't speak of this. We don't speak of Voldemort. We don't speak of failure. So name it. And it's one thing to share your stories, but say the word failure. It's going to be so powerful to our learners as we hear it. So when you speak its name, you take away its power over you, you take away its fear, and you will rise stronger. So thank you for your time, and I'll leave creepy Voldemort up for your enjoyment. Thank you. We're happy to stick around for questions or comments.